Hello again. This clip is to look at an area that comes up from time to time, particularly for trainees in primary care. The question of prescribing antidepressants for children, adolescents and young people, and whether there is a link to suicide and suicidal thoughts. It's, to my mind, a somewhat vexed area. The guidelines change fairly rapidly and have changed a number of times over my professional lifetime, and I'm quite sure they will change again. So this clip will probably become outdated relatively quickly. There's also the old chestnut of those aged between 16 and 18. Which are classified as children in some domains, but classified as adults in others. So unless the guidelines and the research talks about what specific age bracket you are dealing with, talk of children versus adults is potentially misleading. The research isn't brilliant. It's underpowered. Even by comparison with what passes for normal underpowering within psychiatry. It usually doesn't look with any robustness at the presence or absence of suicidal thoughts and behaviours prior to inclusion in the study. There has not been any study to date that has clearly shown an increased rate of suicides amongst children, adolescents, young adults treated with antidepressants by comparison with controls. And the recent study from Scandinavia by Lagerberg, which was reasonably, in fact quite well powered, certainly doesn't show any increase in suicide. And there is the issue then of potentially denying beneficial treatment to people because of a concern that may be more will-o'-the-wisp than real. But of course, it's relatively easy to measure the hard outcome of whether suicides have taken place. The softer outcome of whether there's been an increase in suicidal thoughts and behaviour when treating an area and an illness that has suicidal thoughts and behaviour going with it is more difficult. It's enough to drive you to drink, although this is an espresso, but you really don't want to find yourself on the wrong side of this vexed issue, and there are some things that you can say. So starting with the BNF for children, it says, I'm quite interested to read this, that antidepressants can be considered for children aged between 5 and 11, although it counsels that there isn't any good evidence for this. And the question of antidepressants for those aged between 5 and 11 is fairly easily dealt with from the perspective of primary care, and it's answered by simply saying, just don't go there. Antidepressants for people aged between 5 and 11 is very, very, very clearly for secondary care and should not be considered in primary care. The BNF then goes on to say that for those aged over 12, following a multidisciplinary review, antidepressants can be considered along with psychological treatment as an alternative to psychological treatment alone. So it is implying that it's secondary care consideration, but it's not entirely explicit. And again, because it talks in terms of children, it is unhelpfully agnostic as to whether a 17-year-old is a child or not. It does say, in fairness, that if you are looking at an antidepressant in children and adolescents, it's fluoxetine with more monitoring than you would usually do, particularly on initiation and particularly after any dose change. What does the BNF for adults say? Well, under the heading Suicidal Behaviour and Antidepressant Therapy, it says the use of antidepressants has been linked with suicidal thoughts and behaviour. Children, young adults, and patients with a history of suicidal behaviour are particularly at risk. Where necessary, patients should be monitored for suicidal behaviour, self-harm, or hostility, particularly at the beginning of treatment or if the dose is changed. Now, rather unhelpfully, it doesn't define what a young adult is and when you cease being a young adult. And of course, the phrase "where necessary" begs many questions which it doesn't answer. So, what about NICE? Well, NICE at least talks in specific age brackets, and in the age bracket of 5 to 18, it says that fluoxetine can be considered as an adjunct to psychological treatment. So, bottom line, check what the current guidelines are because they'll have changed. For children in primary care, just don't go there. For adolescents, possibly, but a question more for secondary care than for primary care, and always as an adjunct to psychological treatment. The older the person is, the better. Use fluoxetine and do more monitoring than you normally would. Thank you very much.